Hi everyone. This week we're going to discuss bladder cancer management. A few quick facts from NCI and the American Cancer Society. Bladder cancer is the sixth most common cancer in the United States when females and males are combined. When you break it down by gender, almost 3 times as many men are diagnosed with bladder cancer than women are, making bladder cancer the third most common cancer in men and the 11th most common cancer in women. Twice as many men die from bladder cancer than women do. The reasons for this disparity between males and females are not well understood. The average age at the time of diagnosis is 73 years old. Whites are more likely to be diagnosed with bladder cancer than African Americans or Hispanic Americans. There is strong evidence linking exposure to carcinogens to bladder cancer. The most common risk factor for bladder cancer in the United States is cigarette smoking. It is estimated that about half of all bladder cancers are caused by cigarette smoking. Smokers are at least 3 times as likely to get bladder cancer than non-smokers. There are certain occupational exposures that have been linked to bladder cancer. Higher rates of bladder cancer have been reported in textile, dye, and rubber tire industries, painters, leather workers, and aluminum, iron, and steel workers. According to the FDA, use of a diabetes medicine, Actos, is linked with an increased risk of urothelial carcinoma of the bladder as well. Dietary supplements containing aristologic acid, hopefully I pronounced that correctly, have been linked in the same manner as well. People that drink a lot of fluids, especially water, each day tend to have a lower rate of bladder cancer. This might be because they empty their bladders more often, which can keep chemicals from lingering within their bladder. The bladder is a single hollow organ that is shaped like a pyramid when empty. It becomes more oval as it fills with urine and expands. A smooth muscle called the detrusor surrounds the bladder, and folds called rugae line the interior wall. These structures give the bladder elasticity and allow it to expand. The floor of the bladder includes a funnel-like region called the trigone, formed by the 2 ureteral orifices and the internal urethral sphincter. Urine flows into the bladder via the ureteral orifices and out through the internal sphincter. Then there is the top of the bladder, which is referred to as the dome, and then you have the posterior wall, which is the back of the bladder. The wall of the bladder has 4 main layers. The innermost layer is called the urothelium or transitional epithelium. Beneath the urothelium is a thin layer of connective tissue, which contains the blood vessels and the nerves of the bladder. The next layer is the thick layer of muscle. Outside of the muscle is the fatty connective tissue layer that separates the bladder from the nearby organs. Typical bladder cancer presents with blood in the urine, also known as hematuria. However, blood in the urine does not mean that someone has bladder cancer. Hematuria is more often caused by other conditions like trauma, infection, blood disorders, kidney problems, and even certain medications can cause it. Blood in the urine may be seen by the naked eye, so that's called gross hematuria, or is detected by urine testing, so then that's called microscopic hematuria. The urine can be discolored and appear brownish or darker than usual, but it's rarely bright red in color. Less commonly, bladder cancer can cause the changes in bladder habits like having to urinate more often, pain or burning during urination without an evidence of urinary tract infection. But once again, these symptoms of these types of bladder problems, like the bleeding, are usually caused by conditions other than cancer. When bladder cancer is suspected, the most useful diagnostic test is the cystoscopy. Radiological studies such as the CT scan or ultrasound do not have sufficient sensitivity to be used for detecting bladder cancers. Cystoscopies can be performed in a urology clinic, so it can be done right in the physician's office. A cystoscopy is a type of endoscopy, a procedure that allows visualization of the inside of the bladder through a thin lighted tube that contains a camera. The instrument can also take small samples for biopsies if abnormal areas are seen. A tissue biopsy is the most reliable way to diagnose bladder cancer. An intravenous pyelogram, or IVP, is sometimes performed. This is an X-ray test with contrast material to show the ureters, kidneys, and bladder. When testing for bladder cancer, the dye highlights the organs of the urinary tract, allowing physicians to spot potential cancer-specific abnormalities. But this isn't used very often. A CT scan is not normally performed either, unless it is suspected that the bladder tumor is no longer confined within the bladder, but actually it's grown beyond the bladder. And here are some illustrations of what the bladder tumor looks like when the urologist is performing the cystoscopy. There are 3 types of bladder cancer, types of histologic bladder cancer. The most common type is urothelial carcinoma, which begins in the urothelial cells that line the inside of the bladder. Urothelial cells are transitional cells, which are able to change shape and stretch when the bladder is full. Since the urothelial cells are transitional cells, this cancer can sometimes be called transitional cell carcinoma. There are 2 types of urothelial carcinoma, low-grade and high-grade. Low-grade transitional cell or urothelial carcinoma tends to come back after treatment, but rarely spreads into the muscle layer of the bladder or to other parts of the body. High-grade urothelial carcinoma also tends to come back after treatment, but will often spread into the muscle layer of the bladder, other parts of the body, and the lymph nodes. High-grade diseases cause most of bladder cancer deaths. So obviously a more aggressive type of bladder cancer. Other types of histologic bladder cancer would include squamous cell carcinoma that begins in the thin, flat cells lining the bladder, and adenocarcinoma, which is a very rare form of bladder cancer as well. Less than 5% of all bladder cancers are pure squamous cell carcinoma or pure adenocarcinoma. So almost 90% or approximately 90% of all bladder cancers are urothelial carcinomas. The photo on this slide is a high-grade urothelial carcinoma with muscularis propria invasion by the cancer, which is pointed out with the arrowhead. And then the long arrow is pointing to the muscularis. You can see that the cancer cells are invading into that muscularis propria. This illustration demonstrates non-invasive bladder cancer or stage 0 bladder cancer. For bladder cancer, there are two types of non-invasive carcinomas. One is the papillary carcinoma, or which is stage 0A. It kind of looks like tiny mushrooms growing from the lining of the bladder. So you can see that here on the slide. The other one is carcinoma in situ, or stage 0IS. And that is a 0. It's not an O. It's a 0. And 0IS is a flat tumor on the tissue lining the inside of the bladder. So you can see the difference between the papillary carcinoma and the carcinoma in situ. So those are the two types of non-invasive bladder cancers. And the two types, papillary or in situ, and they each have their own stage. Bladder cancer is also divided into non-muscle invasive disease and muscle invasive disease based on the invasion of the muscularis propria, which, as stated earlier, is the thick muscle deep in the bladder wall. Non-muscle invasive disease can often be treated by removing the tumor or tumors via a transurethral approach, and sometimes chemotherapy or other treatment are introduced into the bladder with a catheter to help fight the cancer. We'll talk about that in a minute. Muscle invasive disease is much more likely to spread to other parts of the body and is generally treated by either removing the bladder or treating the bladder with radiation and chemotherapy. High-grade cancers are more likely to be muscle invasive than low-grade cancers. Thus, muscle invasive cancers are generally treated more aggressively than non-muscle invasive cancers. Surgical treatments of bladder cancer. Early stage cancers are most commonly treated by transurethral surgery. An instrument with a small wire loop is inserted through the urethra into the bladder. The loop removes a tumor by cutting or burning it with electrical current, allowing it to be extracted from the bladder. So this is called a transurethral resection of the bladder tumor, or a TURBT. So this is the most common way that most bladder cancers are treated, because most bladder cancers that are diagnosed are early stage, and early stage bladder cancers are treated with a TURBT. A partial cystectomy includes the removal of only a part of the bladder. This operation is usually for low-grade tumors that have invaded the bladder wall but are limited to a small area of the bladder. Unfortunately, most often, because the bladder is the way it is, the bladder cancer isn't just in one spot of the bladder, it's all throughout the whole bladder, or most of the bladder. A radical cystectomy is when the entire bladder is removed, as well as its surrounding lymph nodes. If the cancer has metastasized outside of the bladder and into the neighboring tissue, other organs may also be removed, such as the uterus and ovaries for women. For men, a prostatectomy is usually performed at the same time as a cystectomy, even if the cancer does not involve the prostate. Just the way of their anatomy is, if the male has a cystoscopy, or a cystectomy, sorry. If they have a radical cystectomy, they will also remove the prostate right along with the bladder. Intravesical therapy is when a physician puts a liquid drug directly into the bladder through a catheter. The drug can affect the lining, the cell lining of the bladder without having major effects on other parts of the body itself. So mitomycin is the most common intravesical chemotherapy. It is used for superficial invasive tumors, usually used immediately after a TURBT, and they do it right in the OR. The drug is placed in the bladder for 60 minutes and then it's removed. Or the mitomycin may be used weekly for 6 weeks, and that is given into the clinic. But the same thing, the drug is put into the bladder. The patient must hold that bladder, the fluid in the bladder, and then after so long, it's removed or released. BCG is an intravesical immunotherapy given for non-invasive bladder cancers. So mitomycin is a chemotherapy, BCG is an immunotherapy. This treatment is given once a week, starting approximately 2 to 3 weeks after surgery, and this lowers the chance of that non-invasive bladder cancer to recur. If you have not done so, please read the article about BCG treatment available in this week's reading folder. It explains exactly how those types of treatments work. So systemic chemotherapy can be given neoadjuvantly to shrink the tumor before the patient has definitive surgery of a radical cystectomy. It can also be used adjuvantly when surgery proves that the cancer has invaded beyond the bladder and or there are positive lymph nodes. So if they do this cystectomy and the tumor ends up invading through the bladder or there are positive lymph nodes, adjuvant chemotherapy would be offered to that patient. It also may be offered if the patient has stage 4 disease or the patient has distant metastases. Radiation can be used neoadjuvantly, usually with chemotherapy to shrink the tumor before surgical resection. Radiation can also be used when a patient is not a surgical candidate or if the patient wants to preserve their bladder. However, it is seldom recommended due to the poor response and survival rates that it leads to. Radiation is also utilized for palliation for urinary blockage, bleeding, and or pain. After a patient is treated for bladder cancer, they are watched very closely by a urologist since these bladder cancers do tend to recur. Follow-up cystoscopies are performed right in the urologist's clinic office. As for site-specific data items for the bladder, there are none. So no extra site-specific data fields that we have to collect for bladder. So it does make bladder cancer cases are usually abstracted. It goes much more quickly than other cases that we abstract. So your assignment this week is a very short one since you also have a quiz. If you have any questions, make sure you contact me before you take the quiz, okay? Everyone, if you're like me, I'm sick of winter, so let's think spring. Have a great week, everyone.